All right, good morning, everyone. Go ahead and make sure that you sign in on the chat, and you can go ahead and put on your videos, please. All right. So we are going to go ahead and get started. So any questions from Perfusion 1 from last week? All right, so you should have watched Perfusion 2. So that's what we're about to cover today. So we're going to have it divided up into 2 sections, basically. We're looking at heart attacks and brain attacks. So we're going to spend the first hour on heart attacks. So why don't you guys tell me a little bit about it? What can you tell me as far as what is it? What's a heart attack? What's an acute MI?
It happens when the arteries becomes like diseased, atherosclerosis, which causes occlusion, which impairs blood flow to the heart.
Yeah, exactly. And then when we don't have enough blood flow going to the heart is going to give us the primary symptom, which is what?
Angina?
Yeah, angina or chest pain, right? So that's how we know as far as the ischemic status of the heart. If we have chest pain, then that means that we're jumping on it because time is muscle. And if we have any damage to the heart muscle, it's going to end up getting replaced by scar tissue, and that's going to put our patients at higher risk of actually developing heart failure, okay? So our big thing here is when a patient presents or complains of chest pain, we're working on our ultimate goal of getting rid of the chest pain, right? That is what we want to see gone. That's our major focus, because we know if we have no pain, then we have improved just from an ischemic standpoint. They're getting adequate blood flow, they're getting adequate oxygenation, and we're not having any kind of damage. Patients who are having a heart attack are at risk for sudden death as well, if it's big enough, depending on where the blockage is and so forth. So it's something that we always want to take is, where it's our immediate attention. It may be something that leads into a rapid response. It depends on your facility as well. Some facilities may, actually have
recording
like their
in
own
progress
protocol, basically, as far as what they want you to follow or considered a rapid response. But for the point of this class, we're just going to take it as what we would do if someone was having a chest pain episode. All right. So we know, I think it was Angel, she said that we know it's atherosclerosis, right? What is atherosclerosis?
Hardening of the arteries.
Yeah, well, it's basically, we know we have arteriosclerosis where they do harden and they lose their flexibility as we get older, but we also have atherosclerosis where it does develop plaque within those arteries, and those arteries over time will narrow off and they can completely occlude, okay? And we know that that happens with issues over time. We don't know exactly the reason. They do feel it's mainly an inflammatory response, and now we know everything's related to inflammation, correct? I mean, we're seeing more and more of our chronic disorders, our autoimmune disorders, it all relates back to inflammation. So we're going to probably see the same, with various ones, like, for example, type 1 diabetes. We know that that's an autoimmune disorder. Type 2, it's not classified as that, but don't be surprised if we don't eventually, have that reclassified as some type of inflammatory or autoimmune response. But everything is inflammation. You see it when you go into the dentist's office for making sure that you decrease, any plaque buildup underneath your gums, because that inflammation in the body can lead to cardiovascular disease, okay? Heart issues, and so forth. So we know that with atherosclerosis that if there's some kind of damage to the artery, whether it's hypertension, diabetes, smoking, then high levels of cholesterol circulating can deposit, and then over time kick in that inflammatory response, and that's where we see the plaque development, okay? So when we talk about risk factors, what risk factors are we focusing on?
The modifiable ones.
Yeah, anything that we can actually address or change, okay? And look, be happy that you guys are home today. We're in the building and it is so hot. It's actually finally, I think it might be finally somewhat getting to a normal temperature, but it was so hot this morning. I was like, I wish I was back on Zoom in my cold house, right? All right, so yeah, we're gonna look at anything that we can modify. So whatever the patient has that puts that patient at individual risk, that's what we're going to focus on. And even if it's an uncurable disease, such as diabetes, we know that we can manage it to help decrease their risk. So even though it's a disease process that we have no cure, we can manage it well. And that's what we want to focus on. All right. So let's get into our scenarios. So do y'all have any questions about heart attack or acute myocardial infarction? That's the big term, the big girl terms that we use and that we see in the chart. No? Alrighty. Let's go ahead and start. I'm going to go ahead and share my screen. And we're going to work through this scenario, and then we have some clinical judgment questions that we're going to go through as well.
Actually, Ms. Hanhart,
Uh-huh.
I do have a question. When I was watching the lecture, you were talking about the risk factors about metabolic syndrome. I'm still unclear of what that is.
Metabolic syndrome is a cluster of risk factors, and it has to do with insulin resistance, how big the waist is on a patient. Usually if it's for females, it's usually over, I believe it's 35 and over 40 for males. It's not, you're on the progression of diabetes, but not necessarily diabetic yet. So you have an increased resistance, your A1C may be progressively climbing, and you have what we consider hypertension or pre-hypertension. Those are the main things that those three factors, when combined, will put you at higher risk for cardiovascular disease. And we call it metabolic because it has a lot to do with the resistance associated of insulin, which is going to increase abdominal fat, waist, and so forth. So does that clear that up for you?
Yes, thank you.
All right. Let me go here. Let me go from the beginning. All righty. So we're going to go ahead and get started. And if you have any questions, just interrupt me because I can't see everyone. All right. So this is the scenario that we're looking at today. Mr. Williams is in 106B. He's a 65-year-old male admitted to your unit the shift before. He presented with intermittent chest pain. His initial cardiac panel was negative and initial EKG indicated ischemic changes, but he had no ST segment elevation. He admitted to the hospital with the diagnosis of acute coronary syndrome with further lab EKG testing ordered and possible angiogram. You just received report and he calls the nurse's station and states that he's having chest pain. So what stands out to you in this scenario so far? Nothing?
Well, he reports chest pain.
Yeah, he's complaining of chest pain. I see, Jamaica, you were about to speak. What were you about to tell me?
The indicator ischemic changes, saying that he probably had a heart attack.
Okay, EKG is indicated ischemic changes, right? So this is one of those scenarios. There's no ST segment elevation. And what do we mean by ST segment elevation? So that's a STEMI versus a non-STEMI. And what's the difference between the two?
One you have time and one you don't.
Yeah, one is more severe, right? So whenever you see ST segment elevation on an EKG, that's turning into an emergency. And that patient we're going to be bringing straight into the cath lab. Because what is the gold standard, the hallmark treatment that we want to do for someone experiencing an acute MI? What's our number one overall goal?
The chest pain.
We want to resolve the chest pain. And how do we achieve it? Do we do it through TPA or do we do it through the cath lab?
Through the cath lab?
Right, because we're revascularizing. So our gold standard of treatment for someone experiencing an acute ischemic ST segment elevated MI is to get them into the cath lab as soon as we can. Does every facility have cath labs? So what do we do?
Send them out to the nearest.
Get them stable,
you
then
try
transfer
to.
'em?
Yeah, you'll have to get them stable and then transfer them. So most of your facilities that don't have a cath lab and someone is having an acute ST segment elevated MI, which is the more severe, then that's when we can actually use TPA. Although TPA is the gold standard for strokes, revascularization in the cath lab is the gold standard for heart attacks. Okay, so if it's not available, then we look at giving a patient TPA. I actually had a patient, this was a few years ago, I was pulled down to the ER. I was the extra nurse in ICU, and this patient came in, and he smoked. He had a history of smoking and hypertension. And he had family history, but he wasn't obese. He was actually on the very thin side, and they rolled him in off the ambulance. He had EKG was good, but he was having these classic signs and symptoms of an MI. His initial labs that came back were still negative. So they said, well, with his risk factors and his chest pain, and it took a lot to actually get him free of pain. He had 3 sublingual nitroglycerins between the ambulance and in the ER. I ended up having to put him on a nitroglycerin infusion. He had morphine, he had the whole gamut of, aspirin and so forth. He was on oxygen. And finally, with the infusion of the nitroglycerin, we finally got resolution in pain. So they said, it took this much, let's admit him, and we're going to do serial EKGs in the along with, enzymes and so forth. So they admitted him to ICU for close monitoring. So I was the extra nurse, so I was bringing him up. So he was going to be my patient. So when you're transporting an ICU patient, usually you have them connected to a little portable continuous monitor. So he was on one, he was connected to oxygen. He was on 2 or 3 liters the whole time. We didn't really have to increase him too much. He was on his nitroglycerin infusion, and he was stable. He was free of pain. And right in the middle of the elevator, as we're going up to the ICU, he goes again, gripping his chest. He's in fetal position, complaining of 10 of 10 pain. And I look over at the monitor, and he went from a normal sinus rhythm, where he now has this massive ST segment elevation that was on the monitor. It was clear as day. So as I'm getting out, that was the beauty of working for a teaching hospital, because as I'm coming out the elevator, I just banged on his door, the resident that was on duty. So you always have a doctor at a teaching hospital. So of course, our cath labs were completely full. We had patients in procedures, they couldn't really stop. So we got TPA on board. Within about 15 minutes, we got it from the pharmacy, because he was having this massive ST segment elevation. And it resolved during the infusion within about the first 5 to 10 minutes. And then he was completely free of pain. So usually with cardiac patients, the time frame is anywhere from 12 to 24 hours, all the way up to, like, you've seen different remarks in the literature where some say, oh, you can only give it within the first 12 hours. Some say within the first 24. But you can use it as a backup in case the cath lab is not available. And that's what we did. It's not the gold standard that they want to use for cardiac patients. However, it is for stroke patients. Why? I'm not 100% sure, but this is what, I'm sure it has to do something with clearing out, the different vessels. You can have multiple issues within the cardiac. So I would assume it has something to do with that. But just keep that in mind, that your heart patients, gold standard cath lab. Your stroke patients, gold standard TPA. Okay. So we actually resolved his chest pain, and they waited about 3 days to go in and take him to the cath lab. And why do you think we waited 3 days? Why did they not bring him in sooner than that?
Bleeding precautions.
Yeah, because remember, TPA, it can hang around in the system for a couple of days, and they want to make sure that it's completely cleared, because we know that when the patient goes into the cath lab, we're entering an artery, correct? And we always have concerns if we're entering an artery for potential bleeding. So TPA, it's not an anticoagulant. It is a clot eater. It's a clot buster. It goes in and it eats up every single clot in the patient's body. So we don't want anything that can potentially, we're not going to go poke around in his artery until that medication is cleared. Okay. So on this patient, there's no ST segment elevation. Okay. So he admitted to the hospital with acute coronary syndrome for the lab EKG testing, which is pretty normal. Every 6 to 8 hours or so, you'll do an EKG. And why are we doing lab testing too?
Checking
So-
levels.
Yeah, we're checking for labs, right? All of your hospitals are going to have a cardiac panel that they use, and it could involve 2 or 3. It could involve, troponin, CKMB, and myoglobin. It just depends on the facility. But troponin is the one that shows up the fastest. So sometimes when your patient comes in and they're complaining of chest pain, they just got there soon enough before it actually showed up in the blood. But it's not as specific as CKMB, and that shows up a little bit later. So that's why those labs may then turn positive, or what we call a bump. They have a bump in their troponin, because this is not normal. We don't normally have this in our patients unless they're in, advanced heart failure. So we're looking for any of those changes, because that may tell us if we missed it on the EKG or didn't catch it. It's going to show that they actually did have, or confirm that the patient had ischemic damage. Okay. So your patient calls, you're right at shift change, you just got report, and he's calling with chest pain. Okay. This is going to be a team approach. Every hospital has their protocol for chest pain. But usually, if you're on a unit, it's going to be a team of you and a couple of other nurses that are going to jump right on this and descend upon it. And you're going to be intervening and assessing at the same time, because time is muscle. Okay. As far as facility specific protocols, you may have them. One hospital I was at, you had one nurse that had to call the ER doctor, and they shoot it down. They had a tube shoot that sent the EKG down. It was just different processes. Everywhere is going to have different processes, but we're going to learn the basics and what you should anticipate. Okay. So you're on this telemetry unit. What might you want to grab as you're heading to your patient's room, the one that's complaining of chest pain?
An EKG machine?
Yeah. And what else is going to be pretty important too?
Set of vitals.
Vital sign machine.
Yeah, vital signs. So if you don't have, something in the room already, you're going to want to make sure that you bring, your Dynamap or whatever equipment they use. Labs, do you think labs are important?
Mhm.
But do you
Yes.
think at this time I'm going to worry about stopping and grabbing my blood, my blood draw supplies and my tubes right now?
No.
No, it is important. It's going to be a little bit lower on that process, right? Because we got to act fast. And why is it so important that I'm taking both the EKG and a vital sign machine?
I check blood pressure.
Yeah, and because what is the main drug that I'll likely give this patient?
Nitroglycerin.
It's nitroglycerin, and what does it do to the blood pressure? Yeah, and we also, it's to establish basic hemodynamic status, right? Is the patient stable? And let's see his blood pressure. Because if the patient's unstable and having chest pain, you may then be progressing to a rapid response or some type of code situation. Okay, so we're going to pull that in there, and you're going to be doing things. You're going to be assessing and intervening at the same time. You may have another nurse that's coming with you in the room, and as you're assessing and maybe applying oxygen on the patient, that nurse may be getting vital signs, and another one may be hooking up the 12 lead. So we usually do this as a team approach. Okay. What do you think would be your first question as you enter the room?
How's the pain? Where is it? How does it feel?
Yeah, we're going straight to the problem here, right? Because our goal is going to be resolution of pain. Because when we know that that patient is no longer in pain, that they have an improvement in the blood flow and oxygenation to the heart. So we're all about the pain. We want to know, okay, where are you having pain? How do you describe it? How do you rate it on a scale of 0 to 10? Is there anything that brought it on? Any precipitating factors? Is there anything that you do that makes it feel better? You want to know all about it. You want to ask them if they're having any type of palpation. Like you're looking for but are you going to ask them palpitations? No. What are you going to ask them?
Do you feel like your heart's skipping a beat?
Yeah. Is your heart skipping a beat? Do you have any type of fluttering? Does it feel like you have butterflies in your chest? Is your heart racing? Those kind of things where the patient can let us know, right? What else might you be asking him about?
Current medications.
Yeah, but you think this is the time to worry about current medications?
A
That might be
history of
something that we're going to get further down, right? But remember, this
Short of
patient was
breath.
already admitted. He has been admitted to your unit because he came to the ER. He had chest pain. They didn't find anything, so they admitted him to telemetry to see if he has any more rounds, and we'll do serial enzymes and EKGs. So
probably
what else
ask-
is most important right now?
You could probably
Are you
ask if
feeling short
he
of
ever
breath?
had.
Yeah, do you feel short of breath? Are you nauseated? Or do you feel like you're going to throw up? Remember, we're going to keep it very simple. Are you dizzy? Okay. And what are you observing with this patient as you're asking these questions and intervening?
They feel like
Diaphoretic.
Yeah, you're looking, are they diaphoretic? Are they discolored? Do they have any cyanosis? Are they using their accessory muscles? Is there any JVD? You're taking all this in while you're assessing and intervening. And when I say intervening, what do you think is going to be one of the easiest and first things that you can do, especially if they're short of breath or they have a decreased pulse ox?
Elevate the head.
Oxygen.
Oxygen, because what's the problem? We're not getting enough blood flow. We're not getting enough oxygen to the heart, and our demand is up and our supply is low. Okay, so we're going to be probably, as I'm assessing that patient, as I'm sitting there and asking him about his chest pain, I'm probably applying my oxygen at the same time. Remember, your core treatments that you're going to see are your MONA treatments, right? Your morphine, your oxygen, your nitroglycerin, and your aspirin. But is that necessarily the order we might do things? No, and every facility may have a different protocol. Some facilities may say, okay, you only do the morphine after you do this, or you only apply the oxygen if the pulse ox is this. However, the standard core of treatment is still our morphine, oxygen, nitroglycerin, and aspirin. Okay, so if this patient, especially if they're short of breath, I'm applying it, right? While I'm assessing it, while my coworker may be getting their vital signs, while my other coworker may be getting an EKG, okay? So after I apply the oxygen, where do you think I'm going next? What medication might be most important to go ahead and administer at this time?
Nitroglycerin.
Yeah, definitely we're going to be looking at our nitroglycerin, right? Are you going to go leave the room to go get the nitro?
No, someone else will get it.
Yeah, have someone else get it. What else might you want them to get?
Aspirin.
Yeah, if they haven't already had a daily aspirin, you're going to want them to get the aspirin, so you can go ahead and give them the first nitro and then follow it up with the aspirin. What's the point of giving the aspirin?
Prevents clots from getting bigger.
Yeah, it's actually an antiplatelet aggregator, so it helps to keep all those clots. So if you have a thrombosis in a narrowed coronary artery, and it helps to keep the platelets from coming in and making the clot even bigger. Okay, so that's what we're going to give them. What are we going to check before we administer that first nitroglycerin? We have our pain assessment. What else do you want to make sure you have?
Blood pressure.
Yeah, blood pressure, right? So how often can we give nitroglycerin?
Every 3 to 5 minutes.
Every 5 minutes.
Yeah, it's up to every 5 minutes. And basically we can give up to 3, okay? So you gave your first one, it's been 5 minutes. What do you want to do right now?
Take the blood, assess pain again, and then
take blood pressure if it's still
Yeah,
if
so you're
pain
gonna
is
be
still
doing
high,
Q
and then-
5-minute vitals on this patient. You're gonna be reassessing their pain, doing your Q 5-minute vitals. And why am I checking vitals again?
So you don't want to give it if the blood pressure is below 50.
Well, 50, we have a problem. We're getting into code status here for systolic of 50, but we are going to want to monitor, make sure that we're not bottoming the patient out. What's the magic number that we usually use as far as blood pressure? Where we might want to consider holding.
90 and 60.
90 over 60, right? Now, if your patient is now 90 over 60 at this point, then that would be something to either discuss with the healthcare provider or, you know, with the rapid response team. I can tell you that with that little patient scenario that I gave you before, with the man that ended up having a big ST segment elevation, his blood pressure was in the 80s. Once we had him on the tridal infusion, and we're looking at risk versus benefit here. So it's not going to be your decision, but it's going to be the decision of the ER doctor, the cardiologist, where, yeah, their blood pressure may be low, but we have pain controlled, right? They're still awake and alert and oriented, and we can do things to help support them, like maybe lay them flat, put their legs up, you know, not extremely high. You can stack them up a little bit on a pillow to just help support it. But just be aware of that it does lower it. But, you know, once we get below 90 over 60, that's where you might need to get some, you know, confirmation from your healthcare provider or your rapid response team as if you're going to continue more. Usually, if their blood pressure is elevated, it's not going to drop it that fast immediately. Okay. So what might the patient complain about at this point?
Headaches.
They may have headaches because we're doing mass vasodilation. Okay, and that's an expected side effect that we might see. It's nothing that we're going to hold the medication for. Okay, so we can go ahead and we're going to reassess every time at the end of the 5 minutes. So if it hasn't been resolved, the chest pain, and his blood pressure is still good, then we're going to go ahead and give a third one. Okay, what happens if after the third one, your patient, Mr. Williams, says, well, my pain's improved. It was a 10 of 10. Now it's a 3 of 10. Are we like good with that? No, because we want a total resolution of chest pain, right? So what can we move to at this point?
Morphine?
Yeah, we can go with morphine, right? And why we give morphine and not Dilaudid?
Dilates.
Yeah, morphine is going to help with vasodilation, so it's an added impact with that. So you'll see a lot of your cardiac patients, heart failure patients, all that, we'll go ahead and give them morphine for pain control, because even with your cardiac patients, that vasodilation will help decrease that preload and that afterload as well that we talked about last week. So that's basically our standard of care. Now, if we apply the oxygen, if we give them nitroglycerin times 3 sublingual, if we give them morphine as ordered PRN, and we still don't have a resolution of pain, then we're probably moving into the direction of having, you know, a continuous infusion of nitroglycerin. Okay. If there's ischemic changes or an ST segment elevation on the EKG, then this patient is likely going to get bumped up into the cath lab schedule, if not more emergently too, if it continues on and just nothing is resolving it and they have EKG changes. Okay. So your objective data is more making sure that you get those vital signs down, get that 12-lead EKG, and then we're probably going to draw labs at this point. Okay. So we're assessing and intervening, and then you're probably going to finish your focus assessment of your cardiac function. So what might we listen for? And you can be doing this also in between, given your nitroglycerin and your aspirin. So these are all things that we want to focus, because we're doing that focus assessment when it comes to our cardiovascular function. So we might be listening for additional heart sounds, any type of murmurs. What do you think we're going to be palpating? Nothing.
The pulses.
You just won't touch them, right? Yeah, pulses, okay. What does their skin feel like? Their radial pulses, these kind of things. A lot of times I've been in many situations of patients having chest pain. And as I'm talking to them and applying oxygen, I'm also feeling their arms and feeling their pulses while I'm talking to them, while someone else is getting vital signs. So don't think that this is not something that we don't convene upon, and we do things, we're assessing and intervening at the same time, okay? So here's your assessment. He was lying in bed, head of bed elevated 45 degrees, awake and alert, oriented ×3, appears anxious, tachypnic, SpO2 98% on 2 liters O2 per nasal cannula, bilateral breath sounds clear, respiratory rate even and non-labored, no JVD noted, complains of chest pain to the left chest wall, radiating to left shoulder and upper back, rates pain 6 to 10, sudden onset without provocation, describes its pressure, complains of slight nausea, denies dizziness or palpitations, BP 145/90, heart rate 115, bilateral upper extremities warm to touch, 2+ radial pulses, regular 12-lead EKG performed at bedside. Okay, so what stands out to you in this patient's assessment?
Pain, respirations, sudden onset.
Now, someone had mentioned sudden onset. Why do you think that's a concern? What was this patient doing? Was he ambulating? Was he pushing a lawnmower? Was he doing cartwheels in his hospital room? What was he doing?
It says he's lying in bed.
Yeah, he was lying in bed. He was not ambulating, no exertion. Is that concerning to you?
Yes.
Yes.
Yeah, so when we talk about the types of angina, where do you think we're moving? In what direction?
Unstable?
Yeah, definitely unstable. It's not relieved by rest or nitroglycerin. If we had to give this patient 3 nitroglycerin plus morphine and he was at rest, we know that we're moving into that unstable where we're really getting into acute coronary, or we running into a STEMI versus non-STEMI event right here, okay? What else do you notice in this assessment?
The heart rate.
Yeah, is that something that we want our patient? Do you think he might be a little nervous? We see that he's anxious, he's tachypnic. His stats are good because he's 98% on 2 liters, right? So we'll probably leave it at that. But what happens when a heart is beating fast? Do you think that's increasing the demand for oxygen?
Mm-hmm.
Yeah, and we're already having a problem. So what order might you get as well on this patient? What additional order may you receive?
Something for anxiety, maybe? Something to bring the
Beta
heart rate down?
blocker.
Beta blocker?
Yeah, and usually labetalol will push it, IV push. We'll use that when we want to bring down a patient's heart rate. Because remember, a heart just sitting there attacking away is putting more strain on that heart. It's saying, hey, I'm going to need more oxygen. I'm going to need more perfusion. And we're having a problem with that right now. So we're going to want to bring that down. Usually we go ahead and push it. What's the concern of patients, especially if they're getting a beta blocker for the first time?
First
Zero.
dose phenomena.
Cardiac?
Feeling good. Orthostatic hypertension?
Well, we know that they can definitely get lowered. It will also affect the blood pressure. But what else do beta blockers affect that a patient may have an adverse reaction with?
The heart rate?
It does
Oh,
lower the heart
angioedema?
rate.
Respiratory. Your lungs,
Respiratory, right? I heard someone say respiratory. Some of your beta blockers, remember, they are selective where they may also work on the receptors within the lungs, and patients can have an adverse reaction and they can go into bronchoconstriction. So that's very concerning if your patient has a history of COPD, restrictive airway disease, whether or not it's sarcoidosis or asthma. How would you know if your patient is starting to have some kind of reaction to a beta blocker, especially if it's the first time that they received it?
Angioedema?
Yeah, it can start out with a little bit of angioedema, a little bit of swelling around the face, around the mouth, around the eyes, and then it can progress pretty rapidly. My husband actually has a friend of his that was started on beta blockers for just blood pressure management. Diagnosed with hypertension as he probably late 40s, and this was a few years ago. So he got put on, it was propranolol, which is the one that is really, so where it will definitely work on those receptors in the lungs. He was on it for about 2 or 3 weeks and he had a delayed reaction. So he was home and he started to feel that his mouth was swelling. He called his nephew to, like, hey, can you go, lived around the corner, can you go grab me some Benadryl or bring it here? I don't have any. The nephew gets there and his whole face is swollen. So they rushed into the ER. They got him just in time. He started to have bronchoconstriction, spasming, and so forth. And he ended up with a temporary tracheostomy because they couldn't reverse it in the ER with the medication. So it can be a severe reaction. So if you're giving a patient a beta blocker, even if they've been on it, make sure that you keep, you watch them, especially if it's relatively new. Like in his case, this was only like 2 or 3 weeks in. Some of your patients, you'll see it right away. So just keep that in mind, especially if they have a history of other lung issues. Okay. So we will probably get an order for a beta blocker to bring down that heart rate. Okay, for sure. Hopefully with the nitrate, do you think that blood pressure is going to come down with nitroglycerin? Yeah, as we start to vasodilate, we'll see a decrease in that blood pressure. Anything else that jumps out at you?
The dizziness, not nausea.
Yeah, complains of slight nausea, denies any dizziness. So that kind of goes along with some of the symptoms that we see with someone having an acute MI, okay? So you can see that this assessment was focused and detailed strictly on his cardiopulmonary status, right? Because this patient having a heart attack, they're at risk for cardiac arrest. So what about the rest of the assessment as far as your head to toe? Are we really worried about that right now? No. So what is your priority for this patient? And we want it done quickly because remember, time is muscle. All right. So we talked about our actions that we were going to take. Of course, we keep in mind Mona, but knowing what the problem is, and that it's a lack of blood flow and a lack of oxygen to the brain. In NCLEX world, even though we're doing all this stuff simultaneously, in NCLEX world, what would be one of your highest priorities or your first action? If he didn't already have it on.
Airway. So
Oxygen, right? Because the problem is that he's not getting enough perfusion and oxygen to his heart. So when we talk about priorities and how are we going to relieve that chest pain, it's going to be applying oxygen. It's going to be providing nitroglycerin, additional morphine if needed, having the patient chew aspirin. Okay. What are some of your, we know that we're going to be getting a 12 lead, right? And we know that we're going to be getting labs. But when you talk about those things that we're going to do in the immediate, in NCLEX world, what would be your lowest priority?
Teaching?
Yeah, but I'm talking about out of what I just said. So between between our Mona, our EKG, and our labs, what would be the lowest priority?
labs.
The lab.
Yeah, it's important, but we need to get them and we need to get them in draw. But remember, whenever a patient is in acute distress, we're going to focus on what is going to immediately affect the patient. Is drawing labs going to affect the patient? No, and really an EKG doesn't necessarily affect the patient, but it helps us understand if there's something going on that we might need to get them to the cath lab quickly, okay? The overall goal is to restore perfusion, revascularize the heart to make sure that it's getting adequate oxygen and adequate blood flow, okay? So when we go back and we're evaluating, we're constantly reevaluating and reassessing our patient. What are we looking for? Resolution of chest pain, right? And we also want stable hemodynamics. We want an adequate blood pressure. We want our heart rate down. We want to have hemodynamic stability. So that's what we're looking for. What do you think that you might do at this time? So you've gotten all this, the patient's stabilized on nitroglycerin and morphine, you gave him the aspirin, you got the 12 lead, you got the labs. What do you think you're gonna be doing at this point?
Probably just monitoring vital signs.
But don't you think, yeah, we're going to continue monitoring, but what's going to be very important, because this patient is becoming worse. He's becoming unstable with his chest pain. So who do you think you're going to have to contact?
Cardiologist.
Oh, definitely his primary or his cardiologist, because we're moving into another direction. So this patient may need to go to the cath lab more quickly. So he reports resolution of pain following nitroglycerin ×3. Okay. So we know we're going to contact the healthcare provider. They arrive, that healthcare provider evaluates the patient, and they move him up onto the cath lab schedule. And they come and let you know he's going to be next up in the cath lab. So what would you do to prepare this patient? You're going to get him back after the cath lab procedure. So what are you going to start doing to prepare this patient?
Definitely want to get a baseline vitals.
Definitely have baseline vitals, and you're going to want a baseline of his distal perfusion in the extremity that they're likely going to use, right? What are the sites that we can use when we talk about a patient going into the cath lab? Which arteries?
Radial, the brachial.
We can do radial, we can do brachial, and we can do femoral usually, right? Why do you think that which artery do you think they're going to go in or access for this patient?
Femoral?
Femoral artery.
Why do you think femoral? Anybody?
Because they're not stable anymore.
Well, they're not stable. And what's the likelihood of us doing an intervention in the cath lab, such as angioplasty, where we're ballooning it or deploying a stent, propping open, or even the interventional cardiologist may go in there and remove additional plaque. So essentially, when you anticipate interventions in the cath lab, they're going in through the femoral because it's larger and they can do more with the equipment. A lot of times your radial and your brachial pulses, arteries, when they access those, it's more for diagnostic angiograms. So just keep that in mind. So being that he is acute and he got bumped up into the cath lab schedule, which distal perfusion do you want to make sure that you pay close attention to? Are we looking at our arms or are we looking at our legs?
Legs, your
Yeah.
dorsal.
So you want a baseline. What do those pulses look like? I'm going to take out my Sharpie and put a little X marks a spot on both feet, because even though they're probably only going to go in through the right side, I'm going to be constantly evaluating both to make sure that there's no difference. So I want to know, are they 1+, 2+ before he goes in? What's the color? Are they cool to touch? Does he have decreased sensation? Because he might have other issues. He might have arterial disease in his lower legs. So we want all of this baseline before the patient goes in. What else are we going to do to prepare the patient?
NPO?
He's going to be NPO, right? They're going to be NPO. This isn't a procedure where they go under general anesthesia. This is one where they actually, they use more conscious sedation, but they can still have aspiration issues. And whenever a patient goes into a cath lab to have an intervention done, there's always a risk that there's a problem and they could eventually have like an emergent CT surgery. So we always make them NPO, okay? They're NPO for their procedure. What else?
Check for allergies with iodine.
Yeah, what allergies might we be looking for specifically?
For iodine for the contrast that they put in?
Yeah, iodine, or are they allergic to shellfish? Some patients may not understand what shellfish means. Ask them, can you eat shrimp, right? Like just different ways we have to ask patients, okay? So it's very important because they can have a reaction to it. But what about other meds that they may be on that can also have a reaction to the contrast dye? What's a very common comorbidity that we see in these patients?
Diabetes.
Diabetes. And what drugs specifically we have to be concerned about if they're on when we mix up with contrast dye?
Metformin.
Yes. Now, if a patient came in, so say Mr. Williams came in and he's on metformin and he took it already this morning, is that going to stop us from bringing him into the cath lab? No, it's not, because the whole point of it is that, yeah, we're going to hold it for a couple of days later. And yes, it can combine with the contrast dye and actually affect the kidneys. But being that we know that, we're going to make sure that we hydrate them during the procedure really well, flush them out afterwards, and then we may also give them additional medications to help them clear the meds. But it's not something that is going to keep us from doing this procedure. It's all risk versus benefit, okay? And right now, the worst problem he has right now is that he's not getting good perfusion to his heart, okay? So, and we usually hold it for 2 days post-procedure. So it's usually a day before if it's planned and 2 days post. But when it's an emergent situation, we'll just hold it for that 2 days afterwards and make sure that we clear the kidneys. So we would also want to be aware if the patient has any renal insufficiency. What can we look at to kind of determine that?
Creatinine.
Creatinine.
BUN and creatinine, good, right? So these are the things that we're looking at, to make sure that we're checking everything we need to check on our patients, okay? As far as our coagulation, we know that they're going to be going into the cath lab and they're going to be accessing an artery. But they're also going to be giving that patient a whole lot of heparin while they're in the cath lab. And why do you think that is?
This is to keep the
So they don't
whatever
make
they
a lot
put
of-
in there from clot.
Right. Think about when a patient goes into the cath lab, they put a sheath in to kind of open up the artery where they have access to it. And they're going to put a lot of guide wires. They may put tools up in there to clean out plaque, tools up in there to deploy the dye, deploy a stent. Well, it's foreign, okay? It's foreign to that patient's body. So just by natural compensation, the body's going to be like, hey, you're not supposed to be up in this artery. So it's going to start a process. And part of that is clot formation. And that can be clot formation on all those tools in the sheath that they're using. So they do heparinize the patients. So that's why it's so important when you get them after the procedure. What are you looking for? What are you going to assess post PTCA?
Bleeding.
Yeah, that's one of your biggest concerns, right? They just tinkered in an artery, okay? And you got a report, and at the top it says, Mr. Williams did fine. He got a PTCA, which is an angioplasty with DES, that's a drug-eluting stent placement to the right coronary artery, okay? He's got a right femoral, and usually they use like a collagen plug to plug off that artery. They'll hold it for so long, they'll deploy the plug, and then they'll bring them to you, and you're going to be recovering the patient, right? So we know that we're going to be looking at that dressing, correct? Right? So what are we looking for?
Saturate.
Yeah, we're looking on any bleeding. Even if there's no blood and there's a hematoma, if there's a big hematoma where that dressing is, that means that they're bleeding inside and it hasn't gotten on the dressing, right? Or they could be bleeding inside and it goes to the back per gravity. So what are we looking for?
Bruising on the flank.
Yeah, bruising around the flank area. We're looking for hematoma. We're looking for active bleeding. If we walk in and we see a hematoma where it is puffed up nice and big on top of the patient's site, what are you going to do?
Blood pressure.
You're going to apply pressure, right? We can't go running out the room screaming he's got an acute bleed, right? Nope. So we're going to hold pressure. We're going to call for help, and we're going to have them contact the interventional cardiologist in the cath lab, and they're going to come over. What else should I be assessing at this point in time when I'm holding pressure? What else do I have someone else do?
Pulses
Blood
on the
pressure.
Yeah, we want to get a set of vitals. Is this patient stable? Is the blood pressure dropping? And what is the heart rate going to do if the blood pressure is dropping?
Increase.
Yeah,
Rise.
it's going to increase. So we're going to see a change in their vitals from baseline. We're going to be holding pressure, okay? And normally, 99% of the bleeds that I've seen post PTCA, after pressure and so forth, we haven't had any issues. I haven't had any that have really gone to surgery. It's just more of holding pressure, okay? Where they had to go do like any kind of cut down procedures or anything like that. So this is something that generally it's going to be holding pressure. I've seen cardiologists hold pressure, well, more like the cath lab tech sometime for up to 45 minutes to an hour, okay? Especially if they're they have a lot of, anticoagulation on board. We'll sometimes see that, okay? So what else are we assessing? We know we're assessing the site and we're looking for bleeding and we're assessing their vital signs because that's also would indicate bleeding, right? Where maybe we couldn't see it. We're assessing their flank for bruising. We're looking for a hematoma or a bloody drainage. What about their distal perfusion?
Checking pulses.
Yeah, we're going to be doing that distal perfusion. We're looking, is it the same? Are they the same on both sides? Is the coloring the same? Are the pulses, sensation, all of our P's? Because the patient may not be bleeding, but maybe something altered the blood flow. Because remember, they just tinkered in an artery. So anytime an artery can be potentially involved, we need to make sure that there's no issues, right? That they're still getting distal perfusion. How many of y'all have looked at flow sheets or taken care of a patient who was in restraints? Those flow sheets, the restraint flow sheets, you're also checking distal perfusion on their hands because what can you occlude off? An artery, okay? So anytime there can be artery involvement that we can occlude off or where we don't get any distal perfusion, cast, like if a patient has a cast or even if they have a traumatic tissue injury and their leg is swelled up really, really big and it can cut off their perfusion, that's something that we're always looking at, right? Because it can fall on you if you don't pick up on that because that patient can actually lose their distal perfusion and potentially have a lot of harm and damage and lose their extremity, okay? So what else are we assessing? We know vital signs, we know the site, flank area along with the bandage. We're looking at distal perfusion. What else? We also, we know we're going to look at level of consciousness as well, because that's always can be a perfusion or oxygen problem. But what about pain? And what pain specifically?
Chest pain.
Chest pain, right? Because remember, they have gone up through a patient's femoral artery, crossed over the iliacs, gone up the aorta. Now they're in the coronary arteries that feed the heart, okay? Do you think they could ever accidentally nick an artery and it can start leaking?
Yes.
Yes, okay. Or we can have a reocclusion of an area. Maybe they went and dug out some of the plaque, or maybe the stent that they put in dislodged and now it's causing a blockage. So we're always looking for chest pain. So if your patient who's fresh post PTCA is complaining of chest pain, it's an emergency. You're contacting, they're getting in there because it could be a reocclusion and they're having another acute MI. It can also be where they did nick an artery and it's now leaking into their pericardial site or their pericardial cavity. And we call that a cardiac tamponade. So basically what that is, that little area is filling up with blood where the heart sits. So if it can't expand, okay, it's not gonna be able to pump if it's filled with blood. So I have seen these. I've seen about 2 or 3 of them in my career where they turned into, and that's a CT surgery emergency. That's why we have to have CT surgery on hand if we're doing interventions in the cath lab. Because if there's a nick where they have to go in and repair an artery, it turns into emergent surgery, okay? So we know what we're assessing and reassessing and what we're looking for, right? So let's say you've been assessing and reassessing Mr. Williams. Usually you do it like every 5 minutes, the first 15 minutes, and then you do it every 15 minutes after that until you reach 1 hour. Then it might be every 30 minutes and then hourly, whatever your protocols are, okay? So he's pretty stable. It's been a couple of hours, everything's looking good. He's not having any problems. So what are some care and comfort measures you could possibly do for your patient at this point?
Lay the bed flat.
Well, we have to keep it flat, right? Because what's the concern? We
Putting
don't want any,
pressure on the artery.
yeah, we don't want any flexion on that hip, right? Where that collagen plug or the closure device is, because if we blow that, what can happen? They can bleed out. And the same thing with your patients, if they go for diagnostic one and they have it in their wrist or their brachial artery, you're going to want to keep that arm straight. They can usually ambulate a lot faster because it went through the arm, but you need to be careful about where you put your blood pressure cuff, right? Especially if you have a CNA that goes in, you need to make sure that they're aware, because even a blood pressure cuff on an arm that has a plug can put pressure and it can blow it. Okay, so we always need to be careful with that. What else? So what if he tells you, look, I was in the ER for 12 hours yesterday. I've been up here. Now it's been 24 hours. I haven't eaten. I'm starving. What do you tell him?
They're not allowed to eat right now. They're clear. They got to start off on clear liquids, right?
But do they have to start off on clear liquids? Remember, we may do clear liquids post some type of surgery that involved abdominal, or sometimes if we're concerned about that, maybe they have swallowing issues after general anesthesia and intubation. But this patient went under conscious sedation. He's stable. He's going to be able to ambulate probably in about 6 to 8 hours. And a lot of these patients may go home within the next 12 to 24 hours. Is there any reason why we can't get him a tray? No, and we can come around and help fix that problem by just, with him flexing at the hip, by just raising the bed and then tilting it and making sure that you just kind of assist them in that they're comfortable. But we can go ahead and feed them and give them something to drink afterwards, as long as there's no problems. What happens if he tells you, oh, well, I have to go to the restroom? He wants to get up and go to the bathroom.
Can't get up for like 6 hours, so you got to get a urinal
Yeah, urinal
or pan.
Yeah, depending on what they need. You're gonna log roll a patient, keep them flat and log roll them to put the bedpan underneath them. You don't want any kind of flexion in that area. And of course, they can't ambulate just yet. We want to always keep wherever they access, we want to make sure that we're not putting any pressure on it. So what might you want to educate Mr. Williams about at this point? I had to move y'all's faces around. So what might you want to educate them about at this point? He's kind of stable, right? He's going to get discharged in 12 to 24 hours, right? What would you want to focus your teaching on?
Maybe the site and the incision site. How to
Yeah,
keep
it's
it.
definitely going to be the incision site. You don't want them soaking in a tub, depending on what they use and so forth. But what about his cardiovascular disease? What do we want to focus on in educating him at this point?
Signs and symptoms to look for, when to call the ACP and when not to.
Yeah, we're going to be looking at can a patient get a stent in, go home and have a reoccurrence of chest pain? Yeah, definitely so. So most of your patients, once they're diagnosed with cardiovascular disease and they have an intervention, they'll go home with PRN nitroglycerin. So we want to make sure that they understand to call their if they're having chest pain, what to do. If they're not relieved with nitroglycerin, then we want them to get to the emergency room right away. We want to make sure that they utilize what to get there?
Ambulance.
Yeah, we want EMS. We want EMS services because they can deploy treatments in the field and quicker, and they can get EKGs. They can have everything notified at the ER rather than say his wife bringing them. What about his risk factors? What are we going to be focused on?
Diet.
Well, it depends on what his problem is, right? It may not be diet. It may be more hypertension, or it might be diabetes control, or not taking his medicine. So whatever we can fix, even though diabetes is not something we can cure, we can manage it. And that's what we want to make sure. So things that we can't change, there's no point in focusing on it. We can't change family history or gender, and those kind of things. So let's focus on what we can change, okay? So here's a few clinical judgment questions we're gonna work through, and then we'll take a quick break, okay? The nurse is caring for a 59-year-old man presenting to the ER with left shoulder and back pain. The nurse reviews the patient's history. Which factors increases this patient's risk for coronary artery disease? These are the types of questions that y'all are gonna see on NCLEX. They might have a ton of options. It may just not be limited to 5.
Hypertension, prediabetes, smoking, family with heart disease.
2 to 3
Pretty
days.
much.
The
So
BMI.
hypertension and prediabetes, we know those are a given, right? Bone fractures, no. Cigarette smoking is a huge risk factor, right? 2 to 3 drinks per month actually doesn't, and depending on what type of alcohol it is, like some, like more of your red wine, that actually decreases your risk for cardiovascular disease, okay? Job stress, do you think that increases it?
Yes.
Right? Any kind of stress, family with heart disease, that's definitely a risk factor. And of course, we know overweight or obesity is also a risk factor as well, okay? Now let's look at these potential orders that you might receive. We're gonna go through and see which one we would consider high priority and which one would be low priority, okay? What about administering oxygen?
High.
Yep, completing a head to toe assessment,
Low.
Low.
obtain vital signs,
High.
High.
obtain a copy of a living will,
Low.
Low.
obtain a 12-lead EKG,
High.
and they also call them ECG, just to let you know. Draw cardiac enzymes.
Low.
High.
Low.
Low.
Actually, it's a high priority on your
Yep.
patient that comes in. It's just out of the treatments that we have, it's the lower one. Okay, but we wouldn't sit there and wait and do our cardiac enzymes when it's time to sit down and talk to them about a living will. Okay, remember, it's lower in our acute phase, but it's still a high priority that we get it done. All right. What about scheduling a cardiac stress test?
Low.
Low, right? All right. I mean, I can't. All right. And what about inserting an IV? I'm moving y'all
High.
around so I can see. Yeah, that's going to be high priority. And if this patient, you might want to put in more than one, right? Especially if we know they're going to the cath lab, we make sure we have good access, good working access too. All right. So let's look out of these. What's that? Let's look at our, these are some lab and test results. So look through them, and then we're going to go through them together and see which one might indicate that the patient's having an MI. So I'm going to let y'all read it to yourselves, and then we're going to do it together. All righty. So 12-lead EKG. Is this indicating that the patient may be having an MI?
Yes, because it has an ST elevation.
ST elevation, that's concerning. What about your white blood cell count?
No.
White blood cell counts really don't play a factor into an acute MI. What about RBCs?
No.
It doesn't really play a factor, but do you think this might be something that we would want to increase for our patient who has decreased oxygen flow? Yeah, so a lot of times you'll see patients, especially if their H&H is low, cardiac patients, when we are now they don't have H&H on here, but then we don't transfuse based off of the red blood cells, but we never want our patients that have a restricted blood flow to their heart to be low with their H&H or anemic, okay? Because that just stresses, something that's already stressed essentially, but it doesn't indicate heart attack. What about platelets? They're elevated, right? So we know that, we're going to want to make sure that we have that aspirin on board to help. It's not going to decrease our platelets, but it is going to help with the aggregation. And we know they're going to get heparinized in the cath lab as well. What about your BUN and creatinine?
They're high.
No.
They're
Yes.
elevated. Both of them are elevated. So that does give us significance when it comes to potential medications, contrast dye, and that kind of thing. However, is that contributing or signifying that this patient has an MI? No. Sodium and potassium?
They're
Yeah.
okay.
The potassium is low. Do you think you might expect an order for a potassium supplement or maybe a K-Rider, which is an IV infusion?
Yeah.
Yeah, although this is not going to play a role, it's a supporting role. It's not the main actor, right? Just like your BUN and creatinine plays a supporting role, this is another supporting role. We don't want our potassium too high or too low because it can cause an arrhythmia. And we don't need to stress any issues more on this heart. So more than likely, you're going to also get an order for a potassium rider, right? We're going to give it IV 10 milliequivalents per hour, diluted in 100 mils. That's the safest way to give it, okay? We know that we can give it through a peripheral line, but the patient may complain of burning. You might have to slow it down. If you have a weary IV, you might want to ask the provider if you can give it to the patient, orally, okay? What about glucose?
Well, don't you want to?
Another supporting actor, another supporting character. It's showing that it's elevated, but remember, he has no history of diabetes. And anytime a patient is stressed or sick, you're going to have an elevation in their blood glucose. So is this definitive to say that he's a pre-diabetic or diabetic? No. What test can we look at?
A1C.
Hemoglobin A1C, which is going to give the patient, kind of give you an idea of the average that the patient's been running for the past 3 months. Before, when we didn't have a hemoglobin A1C, we had to count on what the patient wrote down. Do they ever really tell you the truth about that? No. Okay. I'd have patients come into the ER with the most horrible cellulitis, wounds and this, that, and the other. And you're like, well, can you show me your log, your little book? And you look at it and you're like, they were beautiful, but the labs didn't match what we were seeing. Okay. What about your CKMB, troponin, and myoglobin?
They're all high.
Yes.
Yeah.
Indicator.
Now, your troponin is definitely high. Any bump in our troponin is not supposed to be there. And we also see our myoglobin, but our CKMB is still within normal range. But remember, CKMB is the most specific to the myocardium, and it's right there at the high end, but it takes longer to show up. So I would imagine that we would see in the next labs on this patient, you would see that CKMB increase. Now, does this change anything with our patient, the cardiac enzymes? No, it just tells us, it confirms our diagnosis that the patient had an ischemic event. Okay. All right. So which orders here might you question? And we'll go through them, look over them, and then we'll go through them one by one. And then we'll take a quick break.
Oxygen to keep saturation less than 95?
Yeah, so read through them and then we're going to go through them together. All right, continuous cardiac monitoring. No question on that. What about your oxygen?
Yep.
Yeah, we would definitely want to make sure that we would question that because it just goes against our principles of what's going on, right? What about our nitroglycerin?
Yep.
Yes,
Why would we question the nitroglycerin?
because it's supposed to be
Because you want to give it 3
5
times in
Every
5
Yeah.
minutes.
Q5 minutes, right? What about our aspirin?
No, I wouldn't question that one.
Well, but you should, because we only give aspirin once for chest pain within a 24 hours. So you wouldn't give it every 6 hours. Okay. What about morphine?
Yeah, because it says PRN. It should have a designated, duration, like every so many hours.
Exactly. Every 4 hours? Is it every 6 hours? Every 2? What about a metropolol?
I thought there's
What would we normally be given this for and
Don't you need
why?
a heart rate to hold it?
heart rate.
Exactly. There's no parameters, right? You want me to give metropolol 5 milligrams IV every 2 minutes is tolerated for 3, but what's our end goal here? Do you want a heart rate at this, okay, or at that? So there's no parameters. What about this? Begin cardiac rehab tomorrow. You think this patient's going to be up on a treadmill tomorrow?
No.
Prepare for cardiac cath this afternoon. No issues, right? You would want some more specifics, like NPO, but we're smart enough to know to make our patient NPO and go through the checks that we need. Okay, what about a chest x-ray? All righty. So, last one. The nurse documents the patient's response to the care provided. Which findings require additional nursing action? And in the NCLEX Next Gen, they'll have it where when you hover over, it highlights yellow, so you can click on the areas that you would want to say, hey, this needs additional action. Anything stands out to you guys?
Sipping water.
Sipping water, because he should be NPO, right? What else?
His blood pressure is kind of low, it's like 90/65.
Yeah, but but if this patient received nitroglycerin and morphine, is that an expected side effect?
Yes.
Or is that an adverse side effect?
Expected.
Right. So we're just going to monitor, right? As long as they have a good level of consciousness and they stay stable as far as with their blood pressure, and we'll support them. Anything else?
Well,
The
there-
bed in the highest
Highest
position.
position.
The bed in the highest position, right? Because we still want to keep our safety in there. All righty. So why don't y'all take a 5-minute break, and then we'll come back and we will finish up with stroke.
I have a quick question for you, Ms. Howard.
Uh-huh.
Can you go back to the previous slide just so we can talk about it?
Uh-huh.
All right, so the PTCA in the next hour, right?
Right.
PTCA is still going to be administered even if all of the other, like the pain relief after delivery of nitroglycerin and morphine, all that stuff is taken care of. We're still going to roll with that.
Oh, no, they're going to still bring them into the cath lab and evaluate their chest pain. Remember, the chest pain is a result of something that had a diminished blood flow. So just because we gave him nitroglycerin and morphine and it resolved it, it doesn't mean that it cured the problem of having a narrowing, or you have some kind of thrombosis or something like that. So they'll go in and they'll look for blockages, and any type of blockages, they'll go in. An angiogram is when they look, an angioplasty is when they look and balloon, and then you can do an angioplasty with stent placement where they look, balloon, and deploy a stent to keep it open.
All right, thank you.
Excuse me, Ms. Hanhart.
Yes.
You were saying after the PTCA treatment, if we're seeing any bleeding, we're gonna hold pressure. Was that also if we see hematoma?
Yes, because all a hematoma is bleeding underneath the skin. It's just not coming out on the dressing. You would also hold pressure if you saw a ton of bruising on the back, because they're still bleeding and they're just bleeding into their retroperitoneal area.
Okay.
And you'll hold pressure and you wait and get someone else to go and notify, and then they'll usually come in and evaluate what's going on.
Okay, thank you.
Any other questions? All right, let's take about 5 minutes. All right, we're gonna go ahead and finish up. Okay. So let's go, we're gonna go to our next one. So a quick recap as far as now we're switching from heart attack, now we're going to brain attack, okay? So when we look at brain attack, what are the two different types of brain attacks that our patient may have?
Ischemic and hemorrhagic.
Yeah, we can have ischemic or hemorrhagic. Which one is the most common,
Ischemic.
right? And out of the most common, which one is, I'm sorry, I can't type and talk at the same time, right? And I'm only hitting a little down arrow button. But yeah, so, and our ischemic is the most common. It's 90% of all strokes. And then we do have hemorrhagic, which is usually about 10%. And those are the more severe deficits, more potential for fatality associated with it. So that's definitely one. But the more common one that we see, and we have two types. What are the two types of the ischemic strokes?
Thrombotic and embolic.
Yeah, thrombotic and embolic. What do we mean by thrombotic?
Is that the one where it bleeds on top of the brain?
No, that's our hemorrhagic. When we
Oh.
talk about ischemic strokes are the most common strokes that we have, 90%. That means that we have a blockage, basically. We can have it either a thrombotic one or an embolic one. A thrombotic one is similar to our heart attacks, where we have narrowing in the vessels over time. And then we have something that comes along and there's a little thrombosis that cuts off that blood flow. Our embolic is one that we see with our patients who may have vegetation on their valves or, cardiac disorders, where they may throw a clot and it travels up into the brain and it occludes off that area. And that would be our embolic strokes. Normally, embolic strokes, you get the sudden and full symptoms immediately, whereas with our thrombotic strokes, those are ones that tend to have more of a progression, like, as it comes on with its symptoms. Like it may start out with something, where maybe they're a little brain fog, and then moves to they feel some numbness, and then it's weakness, and then they have facial drooping. So usually that's more like a step-like evolution that we see, okay? The key is to check in it early, because what is the hallmark gold standard treatment for an ischemic stroke?
TPA.
TPA. And what's the time frame according to the American Heart Association or American Stroke Association at this time that we can give TPA in from the onset of symptoms?
3 to 4 hours.
It's 3 to 4.5 hours, and it's going to depend on your patient. It's going to depend on what type of stroke they had, what was, the physician or the healthcare provider's NIH scale that they look at, their stroke scale. It's going to depend on where it is in the brain. Are we making any of those decisions if a patient gets TPA? No, we're not, but we do want to make sure that we're aware of certain safety parameters when we're triaging them. When did your stroke start? When were the first symptoms? And then we're also going to want to know safety, because associated with TPA is also, it's not going to go just target clots that are in the brain. It's going to target clots anywhere within the body. So we need to make sure that they didn't have any recent accidents, no recent like chest compression, surgery, that kind of thing. And the healthcare provider is going to go through it. Most of your facilities also has a check sheet that the physician has to go through and sign. And sometimes you may witness it as well, to make sure that they don't have any of these, contraindications before we give it to them, because we can cause massive hemorrhaging. Okay. So our gold standard has to be within that 3 to 4.5. And that's for our ischemic strokes that are the most prevalent. Do we give this to a hemorrhagic stroke patient? No, because then you would have a patient that would die. They would hemorrhage to death. So that's why it's so important that we establish early on what type of stroke is the patient having. So whether or not they're coming in through the ER or whether or not you're working on the floor and one of your patients starts with facial droopiness, what do you think is going to be the first order that you're going to get for that patient? If you're just working telemetry and they're in there and you walk in and they're drooling out of one side of their mouth, it looks like it's dropping, you notice weakness, you're going to call the healthcare provider. What is the first order you're going to get?
CAT scan.
CT scan. You're rolling into CT scan, right? You're making sure that they're stable, checking blood pressures and vitals, and then you're heading down the CT scan, and you're going to stay with the patient, right? Because it's important for them to know, what are we dealing with here? Is it ischemic or is it hemorrhagic? Hemorrhagic, they can either manage it medically, where if it's small enough, they'll kind of manage it, but if it's big enough, they may have to go in and actually do neurosurgery. Okay. So those are the ones that we, maybe a little bit more involved. Hemorrhagic ones tend to have, a change in level of consciousness and all those classic signs and symptoms of increased intracranial pressure, like projectile vomiting, they might have seizure activity, whereas you can still have seizure activity in an ischemic stroke patient, but it's usually when they're at their peak post-injury, which might be about 3 days when we have the highest increase in intracranial pressure after damage, okay? Seizure precautions, what do we do for those? When you get the order that says seizure precautions, what does that mean to you? Nothing, we just do nothing.
Make sure you have suction at the
Suction
bedside.
Yeah, now when we have suction at the bedside, are we gonna do anything? Are we gonna really suction out their mouths?
No.
No, we have it to help contain any secretions or if any emesis, but usually we put the patients in their left, sideline recovery position. It helps to prevent aspiration. We want to make sure that that bed is nice and padded, even if you have blankets. So if, when you order seizure precautions, you want suction available. You want oxygen available, even if you're holding the nasal cannula up to the patient. Do we ever leave a patient that's actively seizing?
No.
A lot of times we have to give them a benzodiazepine to help control the seizure activity. And so we'll send for someone else to go get it while we remain with the patient. Okay. Left side, pad the bed rails. Do we ever want to restrain a patient who's on seizure precautions?
No.
No, and especially if they could end up with like a tonic-clonic seizure, it could cause injury if they're restrained. And you're going to learn more about seizures and the different types when you hit level 3, because not everyone has jerking movements. Sometimes it might be they have what they call petit mal, where it's just kind of like they check out and they might stare off kind of thing. So you'll see different ones, but usually these are with patients who have had hemorrhagic strokes, or if they've had a pretty significant ischemic stroke and with damage to the brain where we have an increase in that pressure, and it usually peaks a few days later. So you want to make sure that, you understand the different orders that you might see. We can never give an exact clinical presentation of a stroke patient because it depends on where in the brain, what type of stroke, where in the brain, and how fast were they reperfused. And remember, deficits on a patient that show up initially may be different 6 months from now. So it just depends. If a patient has residual deficits for long term, that's where we see our patients where they snowball into other problems. You guys might be seeing them in clinical now, where it might be, a little lady, elderly lady had a stroke. She was placed in a nursing home because she had significant right side weakness, difficulty swallowing, has a peg tube, and then next thing you know, they come into the ER from the nursing home because there's an aspiration pneumonia and there's decubitus because they can't move. And then that decubitus snowballs into osteomyelitis and infection and possibly sepsis. Same with the pneumonia. So you see this. So we see a lot of our stroke patients with their long-term considerations. that we'll see down the road that initially started from that stroke. And basically a lot of the times it can be the care that was associated with it, especially with immobility and that kind of thing. So our biggest thing is to make sure that we try to prevent it. We make sure that patients are aware of what to look for if they're at risk. And again, do you want their spouse bringing them to the ER, or would you rather them call 911?
911.
Yeah, 911, because again, a lot of your stroke centers have things set up with EMS where EMS may give them so much information or start treatments that are within the field. And then I've even seen, my husband is, he's a firefighter medic, and he's actually where in some hospitals they're communicating and they're rolling the patient right in straight to CT scan instead of going to the emergency room first. So all of your facilities are going to have different protocols, and all of it is going to really depend on how the patient presents, what part of the brain, and how fast we get them revascularized. Okay, so let's look at this scenario. Mr. Smith is a 59-year-old male with a history of type 2 diabetes and hypertension who was at work when he had sudden onset of right-sided weakness, right facial droop, and difficulty speaking. So anything jumps out to you in that?
Weakness, facial droop, and difficulty speaking.
Yeah, definitely concerning. What about his history? Does type 2 diabetes and his age put him at a higher risk for stroke?
Yes.
Yeah, because again, this is damage. Type 2 diabetes, elevated glucose levels can irritate the arteries within the brain. They can have the plaque development as well, and that narrowing over time. So anything that damages the vessels are going to put all of our patients at risk for cardio and cerebral vascular disease. And it doesn't matter if it's the arteries feeding the heart, the arteries feeding the brain, or the arteries feeding the lower extremities. It's all atherosclerotic and can end up with thrombosis and occlusion. Okay, so he was transported to the ER where these symptoms continue to persist. It has been 1 hour from onset of his neurological symptoms, and he presents to the ER. So what do we know? Is he within that time frame for TPA?
Yes.
Yes.
Yeah, he is, right? We're not going to make that decision, the physician will, but we always gather information to make sure, in case there's any information that needs to be passed along. He lives with his wife in their home in a rural community. He owns a hardware store where he remains active and involved in day-to-day operations. Is that concerning to you? Is it concerning to you right now?
Not right now, but
It is, but it's something that we're definitely going to consider if he has residual deficits, if he owns his own business, if he's the primary source of income within their family, the role changes. So this patient may need extensive rehabilitation. They may need case management services to set up home therapy. It could be a lot of change, but that's, I hit my mouse. It's not gonna do anything right then and there. We're gonna focus on the acute, and then depending on how the patient presents, what is he gonna need post? Most of our stroke patients who have significant symptoms are gonna end up in some form of inpatient rehab before they're transitioned to home rehab, okay? If they're able to go to home rehab. That's why it's so important that we make sure our patients are aware that we need to get treatment quick and early. Okay. His wife talks to Mr. Smith despite his frustration and not being able to answer her questions. Is that significant to you right now? Is that significant to his acute problem right now?
Yeah, because he have a low level of consciousness.
Well, think about it. We know from the content video that you guys watch, when we talk about stroke, it can also affect cognition, right? So that definitely looks like it's screaming to me some form of aphasia, okay? Which is pretty significant for a stroke. That means that he has damage. Usually it's more towards the frontal area where he can understand language. He's having difficulty finding the words to express himself, okay? He can also have receptive aphasia. So these are some of the symptoms that we see. All right. So his wife reports, I got to move y'all out the way here. His wife reports that the past week he has been complaining of episodes where his heart felt as if it was beating irregularly and fast, but then resolved. Is that concerning to you?
Yes.
And why is that?
That could be a sign of
Okay, dysrhythmia, clot.
Yeah, it could be dysrhythmia, and we know the most common irregular dysrhythmia is atrial fibrillation, right? With atrial fibrillation, when the heart is just sitting there and the atria fibrillating, the blood pools, right? And what can develop?
clots.
Clots, right? The clots can break off and travel into the brain and occlude the vessel. We would call that an embolic stroke, right? It's ischemic, but it's embolic because that clot came from somewhere else and broke off and occluded that area. And remember, look at his history over here. He had that sudden onset. It wasn't an evolution that we see with thrombosis or a narrowing. It was sudden, and it was all these deficits that we see. So it's looking more and more that he might have had an embolic stroke, possibly from a cardiac condition. Irregular heart rate, AFib is what we're thinking. So what do you think you're going to get as one of your initial orders in the ER? Besides your CT scan, what do you think we're going to get to evaluate this, what the wife has reported?
An EKG?
Definitely, right? Probably hook them up to continuous cardiac monitoring as well. His wife also states that he has been complaining of pain in his right foot the past week. He's been trying to quit smoking this past month and has been using a nicotine patch. Is that significant to you right now?
No.
Well, it's significant because is that related to possible risk factors?
Smoking? Yeah.
Yeah, definitely, right? That's something what we're going to have to address.
Pain in the
Because-
right foot could be poor perfusion, which might have
Right.
caused the embolism.
Yeah, well, pain in the right foot, usually if it's poor perfusion, it's more that the blood flow is not getting down there. So he might have arterial disease, whereas with clots, it's usually because the blood sits, okay, even if we have DVT. But this is something that we're going to evaluate, and we know that smoking is going to put him at a high risk, and we're going to want to take a look at his foot. But is this our primary issue right now?
No.
No, we're going to focus on the most primary. That will be something that once we get him situated, stabilized, we'll come back in and complete our head to toe and maybe take a look at the foot. Is there a perfusion problem? Do they have any type of sore? Like, what do they mean by his pain in his right foot? His wife reports that he does not eat regularly, does not regularly check his blood glucose, and eats what he wants. And he has a BMI of 33.9. Is that significant to his risk factors?
Yes.
Yes.
Yeah, so this is everything that we're picking up on that this patient may need as far as discharge education, right? Addressing the risk factors that are specific to him. Diabetes management, monitoring glucose, smoking cessation. But is that something that we're going to worry about teaching right now?
No.
No, that's something that we'll prepare for, but this isn't appropriate. He's acute, okay? Let's look at his vitals. Anything concerning to you as far as his vitals?
His pulse and his temperature elevated, blood pressure elevated.
Well, his pulse is elevated, but what is even a little bit more information? Look, it's irregular, right? Definitely irregular. The temp, it is what it is. It's not really a fever. Respiratory rate's fine, but what about his blood pressure? Is that concerning?
Very
Yes.
high.
Yeah, it's definitely high. Do you think that we're going to get an order for a medication to reduce that blood pressure?
Yes.
More than likely. And what do you think, where do you want to bring that pressure down to? What would be an appropriate number thing that we're looking at?
140, 150.
Yeah, we're not going to bring it down to where he's less than 120. Remember, this is a natural compensation when we have an issue going on with the brain or any damage, decreased perfusion. The body's going to increase pressures to help increase that perfusion to the brain. And we don't want a drastic change or difference between the closed CNS and our systemic. We don't want to have where that pressure is rising within the brain and then we knock down our systemic pressure, because that can cause shifts and the brain isn't getting perfused. So it's very common to see your acute phase stroke patients, either when they present or after several days, to have an elevated blood pressure. Depending on your protocols at your facility, they may say only give, they may write an order for medication to only give the BP, systolic BP greater than 165, or MAP, at greater than such and such. So it's very common to see a somewhat elevated blood pressure. More than likely, they're going to bring this one down, but you don't want to get too far down. 150s, 160s, sometimes you'll see. This is his assessment. So he's awake, alert, and oriented ×3, anxious and restless, agitated at times. Does that kind of say anything as far as perfusion to the brain? Yeah, definitely. The speech is slurred and difficult to understand. Facial drooping noted on right side. Perla. You'd also want to make sure that you include the size of the pupil. Right upper extremity and lower extremity notably weaker than left. He does have full sensation. Bilateral breath sounds are clear. So we're kind of getting into the rest of our assessment here. But do you see how detailed our neuro is? Because that's the most presenting problem. Non-labored, SpO2 99% on room air, S1, S2 noted at PMI, telemetry in place, reveals AFib, upper extremity warm and dry and without cyanosis, 2+ radial pulses, cap refill less than 3, abdomen soft and non-tender, bowel sounds positive, continent of bowel and bladder, so he didn't lose that, voids per-urinal, and positive DP pulses, skin intact, okay? So anything that really jumps out, we see all the neuro stuff. So it's really looking more and more like he had an embolic stroke. He's an AFib, right? So he wasn't diagnosed. It wasn't in his history. And so if they weren't on anticoagulation, more than likely this was a clot thrown from his atrial fibrillation, okay? So these are your orders. Okay, what do you think would be most essential to you for you to act on first out of these orders?
The CT head scan?
Yeah, definitely, right? Especially if you're on the ER, on telemetry unit. What else would be important? What's the rationale for some of the other ones? Why do you think we're also wanting to do a 12 lead? Telemetry is showing AFib, so we want to see it in all leads, right? So we definitely want to get that CT of the head. We're going to probably bring that labetalol down just enough to keep his blood pressure within 160 to 180, right? Continuous cardiac monitor. Of course, he's going to be NPO. And why do you think it would be important to make sure that he's NPO?
Just in case they have to do.
Well, they may have to bring him in, but what's even more important? What about, how did he present? Yes, what about his speech?
Yeah,
his
slurred.
speech was slurred. It doesn't mean that he has an impaired swallowing, but we don't know. It could be he could have muscular issues. It could affect his swallowing. Is it common for patients with a stroke to have possible swallowing issues?
Yes.
Definitely. So we're not going to make that decision. Who's going to make that decision of when this patient can eat?
Speech therapy?
Yeah, it's going to be a speech therapy. Usually we're going to get them in, get them evaluated, and they'll consult speech therapy to see whether or not we can actually feed the patient or give them any type of liquids. Because what's the concern?
Aspiration.
Aspiration, definitely. Okay. So the alteplase, if CT is negative, that's a TPA. He's within time frame. We see 2 liters of O2 per nasal cannula to maintain above 95%. He was already sat in 98, 99 on room air. So we're good with that, right? So this is some of the common things that you might see as far as your patient. Once the TPA is on board, we hope to see a resolution of or an improvement in their stroke symptoms if we can get them in time. If this patient would have showed up without, and not in that time frame, do you think that there's much that we can do to improve their deficits? They may bring them into interventional radiology, try to do a thrombectomy to remove that clot out of that area. But if it's for an extended period of time, we could end up with how they presented, it could stay like that. It could be different in a week, it could be different in 6 months, or it could be no changes at all. The brain is very difficult to predict when it comes to how a patient recovers and resolves. But most of the time, if we feel like they're going to be more, if they go through their initial treatments and there's still deficits, you're going to be looking at inpatient rehabilitation, then transition to outpatient, through home health and so forth. And then some patients may end up with these issues. And this is where we see a lot of our patients, especially this semester in clinical, you'll see where they may come in and they have a prior history of stroke, and it's the complications of that stroke, whether it was eating complications and they can no longer eat and they have an aspiration, they have a PEG tube, or if they're incontinent and they can't control their bowel or bladder and they have limited mobility and they end up with decubitus and ulceration. So we kind of see where a lot of our concepts will come together and they can snowball into further problems. And this is what you guys will see when you're in the inpatient setting. Patients always snowball. You'll see where they come in for one problem and then this event happened, that event happened, and then it snowballs into multiple problems, okay? So again, as far as once this patient is ready for discharge, the services that may need to be set up is going to be dependent on where the patient is as far as their deficits, what they can manage. Are they going to need assistance through the social workers or case management? If their roles have changed, that kind of thing. So it's really dependent upon where it was in the brain, what type of stroke, what did it affect, how quick did they get revascularized and reperfused, and that will help the physicians kind of determine what might be their long-term outcome. It's really difficult to predict, okay? So any questions when it comes to our stroke? None.
I have
All
a
right.
question. Oh,
Uh-huh.
I have a question. It's just a random question, but it relates to what is FAST? I know it's face, arm, and what's the S and T?
It's speech, right, and timing. So let's get there fast. It's all about, like, do they have facial drooping, right? Do they have any kind of speech things? Do they have any deficits from one side of the body to the other? And remember, time is money with both brain attacks and heart attacks. The sooner we can get them reperfused and revascularized, that means more chance that they're going to have a decrease in the potential of those residual deficits. It's the residual deficits that makes it so difficult. Okay. All right. So now you guys have this class again tomorrow, Perfusion 3. Am I correct? Okay.
Yes.
So make sure that you review the content video. I know some of y'all had forms, so you may not have reviewed the content video for this. Make sure that you do that one and the one for tomorrow. We won't spend a whole lot of time on arterial disease. It's pretty simple, and I think we'll be able to get to the point between arterial disease and chronic venous insufficiency. And then we'll spend the next hour. We're going to be reviewing all of this content and going through test taking strategies and answering questions and so forth. Okay. All right.
Thanks, Ms. Hanhart.
Y'all welcome. Y'all have a good one.
You too. Ms. Hanhart, real quick.